Well, good afternoon, everyone, and thank you for having me to speak on this platform. It's a great privilege to be able to discuss asthma management in 2021, and with particular reference to how COVID-19 may have changed anything. Here is my disclaimer slide, and I just want to thank the sponsors of this event, and in particular ECIPA, for the role that they play in healthcare in our city, and for Dr. Govinder's input and role in leading that group. So, my fellow South Africans, how those words have reverberated through our lounges over the last 18 months or so. Probably with trepidation if we were going into a wave, and with hope and expectation if we were coming out. But certainly in the years to come, I'm sure if somebody ever says, my fellow South Africans, to us, we're going to have memories of 2020, 2021. So has COVID changed anything? Well, I think we'd all agree COVID has changed everything. Our day-to-day lives have changed significantly, not only in South Africa, but across the globe. Stress, anxiety, depression, and loneliness are more common. Amongst patients, many of them have skipped or even delayed their preventive healthcare visits. Millions of children across the globe have missed their vaccines. At the end of lockdown 1, it was calculated that about 1.2 billion children had been out of the classroom for that period. Our interactions in terms of meetings like this are now virtual, and that's the norm. Social distancing is happening wherever we go, and every personal interaction is social distanced. Sanitizing, no longer just the doctors, nurses, and healthcare workers, it's everybody now. And even how we greet each other has changed forever. So how did we think that asthmatics would fare with COVID-19? At the beginning of the pandemic, my practice was inundated with requests from patients to give them letters so that they could be at home or away from their place of work because they were worried about their disease. And I didn't know how to do this objectively. So fortunately, I managed to access a document circulated by the Western Cape government, which was termed the Individual Risk Assessment for Vulnerable Staff with Potential Work-Related Exposure to COVID-19. And this gave us an ability to assess the individual's personal vulnerability to COVID-19. So if, for instance, you were a recipient of a transplant, or if you had severe COPD or unstable asthma or a disease like cystic fibrosis, you were assessed to have a very high vulnerability and you scored 4 points. If you were over 60 with something like moderate to severe asthma and you were obese, you were a high vulnerability. If you had a controlled medical condition and were middle-aged, you were a medium vulnerability. And if you were young and healthy, then you were considered to be low vulnerability. And then there was the exposure risk. So if you were a healthcare worker doing performing aerosolizing procedures, then that was considered a very high exposure risk. You scored a 4. Normal healthcare workers exposed to COVID patients scored high and 3. And if you were just a member of the public, a teacher, a taxi driver, a shop assistant, you had a medium exposure risk. And if you really did try your hardest and isolated at home, you had a low risk. And then what we did was we had this 4x4 table, and we put your risk and your exposure together and come up with 3 groups of people to try to work out whether this was an acceptable risk, acceptable only under critical conditions, or a totally unacceptable risk. And as we see an example, a 62-year-old lady who is a nursing sister, works in outpatients with controlled hypertension. She has a high vulnerability because of her medical conditions, and she has high exposure because she's seeing COVID-19 patients, and she would score 9 points. It's an unacceptable risk, and we would recommend that she be redeployed into a safer area. So what about asthma? Well, according to that schedule, asthma was considered to be high vulnerability, and if you had uncontrolled asthma, they would consider you to have very high vulnerability. Of course, many asthmatics are in fact also obese. If we look at the general population with a normal BMI, only 7% of adults have asthma, whereas if they are obese, up to 11% of obese people have asthma. So obesity is a risk factor for asthma as well. So this gives you a lot of vulnerability because of these underlying diseases. So the question is, where were all these asthmatics? Because I didn't see them in my clinic, I didn't see them in hospital. And certainly I think that they didn't follow this vulnerability schedule that we expected they might. So looking at a meta-analysis published in February this year, 2021, 41,000 patients, 130 studies looked at. Asthma is not associated with a higher COVID-19 severity or even a worse prognosis. It seems that there's no difference in asthma prevalence between COVID-19s who are hospitalized or not, severe or not, ICU or not. Even their mortality doesn't seem to vary, and whether they were intubated and ventilated made no difference. So asthmatics not at greater risk when it comes to COVID-19. In fact, when you look at what asthmatics did during the pandemic, there was a lower prevalence of asthmatics in COVID-19 admitted patients. So here's a cohort of 768 patients published in European Journal of Medicine, Respiratory Journal, beg your pardon, who were admitted with COVID, and only 4.8% of them had asthma. Now, we know that the background population or the background incidence of asthma is about 8%. So you would have expected at least 8% of that cohort to have had asthma. So there seems to be something else going on. None of those patients that were admitted actually presented with an asthma exacerbation, and only one of them was treated for bronchospasm while they were in hospital. During the lockdown in 2020 in England, Scotland, and Wales, there was a 36% reduction in emergency admissions for asthma, and a very significant reduction in patients needing corticosteroids for exacerbations. And when we look at biologic use in patients with the most severe asthma, it appeared that they weren't at a higher risk of COVID-19 either. So it seems that there's an interaction going on here somehow between asthma and COVID that appears to protect against poor outcomes. And there are a couple of theories as to what this might be. Chronic inflammation may lead to a degree of immune tolerance that could restrict the development of the inflammatory storm that drives the severity in COVID. We know that asthmatics have a lot of mucus hypersecretion, and it may be that that prevents the virus from gaining access to the alveolar type 2 cells where the receptors reside. But probably the greatest reason is that the respiratory epithelial cells of asthmatics have decreased gene expression for ACE2 receptors, and therefore having asthma may in fact be protective against COVID-19 infection. Well, what effects did this pandemic of COVID-19 have on asthmatics? Well, I think it's fair to say that all asthmatics were fearful of what COVID might do to them. And the fear of an exacerbation may have led to there being better compliance. Certainly, they would have complied better with social distancing, avoiding crowds and people who are unwell. Regular use of sanitizers would have reduced the transmission of pathogens. I think asthmatics would have done their best to wear masks, and we'll come to a little bit more about that now. Certainly, in early lockdowns, the avoidance of outdoor pollutants and generally keeping out of places where those would have been found may have played a role. And this would have all led to a general reduction in viral infections. So what about mask wearing? Lots of people with respiratory disease feel uncomfortable in a mask and have numerous reasons why they feel they shouldn't be wearing a mask. But there's no evidence that wearing a face mask can worsen your asthma. Wearing a face mask does not affect your oxygen levels. We know from the ENT literature that there is a reduction in exposure to aeroallergens, which causes a lowering of allergic rhinitis and allergic conjunctivitis. And then using a mask will cause the air to be warmed and humidified, which will reduce cold air exposure, which, as we all know, is a strong trigger for asthma symptoms. And then the very nature of why we're wearing masks during the pandemic is that they protect against respiratory infections, and those include influenza and the common cold. And I think it's common cause that in the last 18 months, we've seen unbelievably few people with other viral infections. Influenza has hardly been documented, and there really has been a significant reduction in general respiratory tract infections, probably for the same reasons that we've elucidated above. So the asthmatics' defenses against COVID really are the big three: social distancing, masking, and sanitizers. But it would be wrong to ignore the very great important contribution that vaccination makes. A few recent comments in the local press have been interesting, and I found this one. What this COVID virus has continued to demonstrate is its ability to find people who are not vaccinated. A catchphrase that's going around at the moment is that we've now moved into the pandemic of the unvaccinated. And this arises from the fact that hospitalization rates among unvaccinated adults is 17 times higher than amongst those who are fully vaccinated. So what about vaccines and asthma? Well, if you look at the most severe asthmatics, those who are on biologic therapy, and this study was done to look particularly at that group, 243 patients received COVID-19 vaccines and none had an exacerbation as a result. We are gaining increasing and worldwide experience with the vaccine, but in this cohort of 64, nearly 65,000 people receiving the vaccine, allergic reactions were really very uncommon. Only 2.1% of that group, just over 1,000 people, had an allergic reaction. And there were only 16 people in the total group who experienced an anaphylactic reaction. And very interestingly, almost 2/3 of those had an allergy history, and about 1/3 of them had suffered a previous episode of anaphylaxis for another allergic condition. There was only one ICU admission and no deaths. So again, although these things happen, no deaths associated with the vaccine across those 65,000 people. There's a complete absence of exacerbations stimulated by the COVID-19 vaccine in asthmatics. And don't forget that vaccination is a routine part of proper asthma management. We're all used to vaccinating our patients against pneumococcal and influenza viruses. So I do believe that this should be incorporated into standard management for asthmatics as well. And the GINA Global Initiative for Management of Asthma supports the vaccination campaign in asthma patients as well. But what about the asthma per se? Obviously, optimizing your lung function by controlling your asthma provides you with a good reserve against any infection. But there are a few specifics. We shouldn't be using nebulization where other people are exposed to the aerosolized nebule solution. And the recommendation is that we convert to pressurized meter dose inhaler with a spacer as a safer way of getting medication in where that's required. And then a specific point about spirometry. In my practice, we stopped doing all lung functions during periods when community transmission was high to protect ourselves and staff. And you certainly should not be doing lung function testing on anybody who has COVID-19 because of the risk of transmission. Many asthmatics will complain or may say they're worried about how to distinguish their asthma from a COVID-19 infection. I think that it's fair to say that most asthmatics know their disease pretty well, and the symptoms of tightness and coughing, wheezing, and shortness of breath that they experience with an asthma attack are pretty well understood by them. Remember that COVID-19 has a number of other symptoms that go with it, such as myalgia and headache, loss of taste, maybe the nausea and diarrhea, vomiting, loss of appetite, that really aren't part of an asthma attack. And so it's probably not too difficult for the average asthmatic to decide when it's COVID-19 and when it's asthma. And I don't think we've been so struggling with that as a problem. So while the COVID-19 pandemic has been raging, of course, life carries on. And there have been some developments in asthma treatment during this time that we may not have been aware of because we're so preoccupied with COVID. So just to take us back a little bit in history, back in 1997, the FACET study looked at the addition of long-acting beta agonists to inhaled corticosteroid to improve asthma outcomes and achieving that at a slightly lower inhaled corticosteroid dose. And that was the first time that people started talking enthusiastically about LABA-ICS combination treatment. That study used formoterol and budesonide. And from then on, there was a growth and expansion of this marriage of formoterol budesonide, driven largely by the company that started that combination in Turbuhaler, being AstraZeneca using Symbicort. And over the next few years, they coined a number of phrases using this agent, formoterol budesonide combination Turbuhaler as Symbicort in what they called single inhaler therapy, which subsequently a couple of years later morphed into single maintenance and reliever treatment, or Symbicort maintenance and reliever treatment, which was an approach to the management of asthma using only one inhaler for both relief and maintenance treatment. But it's based on the fact that formoterol has a rapid onset of action bronchodilator effect. And just to remind you, formoterol and salbutamol have virtually the same potency in terms of bronchodilation effect and rapidity of onset. And you see from this graphic that you're getting 20 to 25% of the bronchodilator effect within about 3 minutes of their use. Unfortunately, salmeterol and other LABAs are not associated with this rapid onset. And so the kind of approach that we're talking about here really is limited to combinations that have formoterol as the active long-acting beta agonist. The idea with this combination is to tailor one's inhaled corticosteroid requirements to symptoms, and that your low-dose maintenance inhaled corticosteroid will be increased as your symptoms increase as you use more of your inhaler. It was noted in Primary Care Respiratory Journal that this would be particularly useful for patients who didn't take their treatment regularly. And we have postulated that many patients really only use their inhalers when they need to, especially those on the milder side of the asthma spectrum. It's been shown by a Cochrane analysis of this approach that it reduces exacerbations and lowers total dose of steroid when compared to fixed dose combination used for treatment of asthma. So SIT became SMART, and SMART has become AIR. So AIR stands for anti-inflammatory reliever treatment. And this is premised on the fact that airway inflammation is key in the pathogenesis of asthma and underlies bronchospasm as the etiology. Symptoms may not always be burdensome. And so until now, what we've done is we've used a short-acting, rapid onset bronchodilator treatment in mild asthma, SABA. And for more persistent asthma, it's been suggested that you move to regular maintenance inhaled corticosteroid with, as needed, short-acting bronchodilator. And the problem is that with all of these, poor compliance is a problem and may lead to suboptimal control. So the over-reliance on short-acting bronchodilator has been a problem, and this has been shown to increase morbidity and mortality. And it's interesting to see that mild asthmatics remain at risk for severe exacerbations. And in fact, they constitute 30 to 40% of asthma exacerbations leading to emergency care and even death. So mild asthmatics contribute a large proportion of the number of people suffering with severe asthma exacerbations. And it's thought that the combination of anti-inflammatory inhaled corticosteroid and reliever medication in a single inhaler could significantly address these problems. In fact, the Global Initiative for Asthma in 2019, in their March-April update, went so far as to say that short-acting beta agonist only treatment is no longer recommended. They wanted us to move away from SABA use altogether, noting that there was strong evidence that SABA only treatment increases the risk of severe exacerbation and death, and that adding any level of inhaled corticosteroid reduced that risk. So they concluded that all asthmatics should receive an inhaled corticosteroid together with a controller combination driven by symptoms if they had mild asthma, and regularly daily for more persistent symptoms, with the same inhaler being used for rescue. Now, it should be noted that the inhaled corticosteroid with formoterol is the preferred controller for steps 1 and step 2 on their schedule. And so the guidelines look something like this now. And if you look inside those red circles, you'll note that as needed low-dose inhaled corticosteroid formoterol has replaced short-acting beta-2 agonist in step 1. It's also done that in step 2. And they're recommending now that we use as needed low-dose corticosteroid formoterol combination or low-dose inhaled corticosteroid as maintenance. And across the board, right through to step 5, it's recommending that our preferred reliever treatment is now as needed low-dose ICS formoterol combination. Now, the studies that gave the information on which this data is based were called the Sigma study. So there were 2 of them, Symbicort given as needed in mild asthma. And these were very big studies, nearly 4,000 patients. They lasted for a year, and they were double-blind, randomized, placebo-controlled, as they should have been. And what they did was they looked at budesonide formoterol as needed, compared with placebo, short-acting beta-2 agonist, and compared with a budesonide as needed in the so-called maintenance group. So budesonide maintenance versus budesonide formoterol as needed. And the second study showed that was designed over 4,000 patients. It was again budesonide formoterol as needed versus maintenance budesonide. Again, a full year of study. And what they showed was that budesonide formoterol, when taken as needed, when compared to short-acting beta-2 agonist, made a significant reduction in the exacerbations by 64%. So a highly significant reduction there in exacerbations. If you compare budesonide formoterol to budesonide maintenance, there was no difference in the number of exacerbations, the severity of those exacerbations, or even the time to the first exacerbation. But what was very significant was the amount of corticosteroid that these patients were exposed to, 78% less in the as-needed formoterol budesonide group compared to those taking maintenance budesonide. And the conclusion then is that in mild asthma, as-needed budesonide formoterol reduces exacerbations compared to short-acting beta-2 agonists and gives comparable efficacy in reducing the risk of severe exacerbations compared to normal maintenance regular inhaled corticosteroid, but with a significant reduction in the amount of exposure to corticosteroid. So in conclusion, I have discussed that COVID-19 has really not affected asthmatic patients to the extent that was expected. In fact, it seems as if the pandemic may have resulted in an improvement in asthma control via a number of mechanisms. And we've also shown that COVID-19 vaccines are safe, particularly in this asthmatic group where there may be significant concern for their safety. And then to just highlight that there have been some major changes in the GINA asthma treatment guidelines that have occurred whilst the COVID pandemic has gone on around us, and that currently short-acting beta agonist use is discouraged in favor of the combination inhaled corticosteroid with formoterol as reliever treatment which is now referred to as anti-inflammatory reliever treatment. The inhaled corticosteroid formoterol as required use can be considered in place of regular inhaled corticosteroid in those milder asthmatics. And with that, I'd like to thank you for this opportunity. I look forward to your questions, and I trust the rest of the afternoon is going to be very educational for all of us. Thank you so much. Bye-bye.